So thank you. Esophageal adenocarcinoma is the fastest rising cancer in males in the UK. Of 100 people diagnosed today, less than 15 will be alive in 5 years' time. At the time of diagnosis, most qualify for palliative therapy or best supportive care. Distant and locally advanced disease prevents treatment with curative intent, a punishing multimodality regimen. Current treatments don't work, and new directions are needed. For the last 30 years, esophageal cancer research has focused on the cancer cells themselves, but we've not altered outcomes. Diagnosis and death runs parallel. Next-generation sequencing studies shows us that the mutational burden of cancer is established early, with 21 of the 25 most common mutations in esophageal adenocarcinoma being present in never-dysplastic Barrett's esophagus. Drivers for progression may lie beyond the tumour cells themselves, and accumulating evidence shows the stroma plays a critical role. The major cell type in the stroma are cancer-associated fibroblasts, or CAF. CAF have a myofibroblastic phenotype, meaning they're contractile secretory cells expressing alpha smooth muscle actin, or SMA. CAF are heterogeneous, but predominantly from the local fibroblast population. Regardless of the progenitor cell, TGF-beta signaling and increased tension in the local environment are central to CAF transdifferentiation. CAF are involved in many of the hallmarks of cancer, especially invasion and metastases. To study CAFs, I collect tissue from the proximal resection margin and tumour of our patients undergoing curative surgery. We grow these out in laboratory conditions without any recombinant technology, and Western blotting and immunofluorescence shows the expression of alpha SMA by CAF, the recognised marker of the CAF phenotype. High levels of SMA are predictive across many aggressive tumour types, and we have shown this to be the case in esophageal adenocarcinoma. It would be nice to try and transfer the benefits of low SMA expression into our patients, but currently no medications are licensed to perform this. An Austrian group noticed an interesting anecdotal finding. In their patients with benign prostatic hypertrophy who have been treated with PDE5 inhibitors for erectile dysfunction, their symptoms got better. And when they looked into this, they showed that in benign disease, myofibroblasts could be reverted to fibroblasts in vitro with PDE5 inhibitors. This is supported by the appearance of PDE5 inhibitors in other fibrotic disease, but it's not yet been shown in cancer. The most notorious PDE5 inhibitor is Viagra. It started out life unpromisingly when in clinical trial for angina, it didn't do the job Pfizer had hoped. However, one major side effect was noted. PDE5 is responsible for degradation of the intracellular secondary messenger cyclic GMP. If you inhibit PDE5, you get increased levels of cyclic GMP, which leads to a cascade of cyclic GMP-dependent pathways that ultimately decrease intracellular calcium levels. Now, PDE5 inhibitors are a very safe drug, and more is appearing in the literature and in clinical practice about their use in tissues where PDE5 is expressed outside of erectile dysfunction. We have confirmed that PDE5 is expressed in the normal esophagus, as previously reported, but also shown that it's present in esophageal adenocarcinoma. And we can see we get PDE5 staining in the stroma. And in our cancerous and normal fibroblasts, we see Western blotting shows PDE5 expression, and this seems to be greater in the cancer-associated fibroblasts than in the normal fibroblasts. At the resolution of Western blotting, PDE5 is not expressed in our normal cancer cell lines used in the labs. This translates into in vitro. PDE5 can significantly decrease alpha SMA expression in CAF lines. Across multiple repeats, so triplicate repeats of 5 different CAF lines, we get a statistically significant effect of about a 50% reduction. This is not something that is selective to only certain CAF lines. And PDE5 sRNA knockdown has confirmed that this is an on-target and class effect of the drug. Functionally, here we have a collagen gel contraction assay. It was designed to replicate the desmoplasia or contraction seen around aggressive tumours. And with PDE5 inhibition, we see almost no contraction compared to vehicle. And again, we've performed sRNA knockdown to confirm this. In a transwell invasion assay, cancer cells in the upper chamber digest their way through a matrigel-coated insert towards a chemoattractant in the lower chamber. When we treat our CAF with a PDE5 inhibitor, wash it away and clean, and collect the secreted fraction from them, we see significantly less invasion towards that medium, the chemoattracted secreted fraction from our treated cancer-associated fibroblasts. Our organotypic 3D culture is a complex model designed to recreate a tumour in vitro. In the PDE5 treated group, we see no invasion or minimal invasion, and without PDE5 treatment, we see large amounts of invasion. In combination with our Dr. Grabowska's group at Nottingham, they've used their 3D spheroid model to give us some further evidence that where you include fibroblasts with your tumour cells, this gives you a chemoprotective effect against the standard of care chemotherapy. But if you include the PDE5 inhibitor, here they've used vardenafil, we see that this protective effect is lost. The surgeon in me would be happy to stop at that point, but the scientist in me wants to try and find out a little bit more about why this happens. And we've performed some weighted correlation gene network analysis on publicly available data sets that shows there is, in the extracellular matrix of esophageal cancer, there is relationship between PDE5 and ACTA2, the gene encoding for SMA. This is also the case we've seen in several other aggressive cancer types, such as pancreatic adenocarcinoma. In order to take this forward, we've patented PDE5 inhibitors for solid organ tumour stromal targeting with the University of Southampton, and working with our clinical trials unit to propose the first human trial of PDE5 inhibitors in esophageal cancer treatment. So in conclusion, we can see that high levels of SMA in esophageal cancer are predictive for poor survival. PDE5 inhibitors in vitro decrease SMA expression, they decrease invasion, and they also seem to lose the chemoprotective effect provided by the stroma. This is a safe drug that is in modern use, and we propose that it should be used to treat patients with esophageal adenocarcinoma.